This is really a wonderful place, isn't it? When I took the elevator down from the John Wayne Airport, 30 feet wide, maybe 15, 20 feet high, was a big display about anti-cancer university. That would be UC Irvine. Just as the first thing I saw coming out of the airport. And yeah, I think this is a tribute to that claim. It's also, as far as I know, worldwide, and I'm not paying too much attention to everything because there's so much else going on in the world, the first definitive AYA-ALL conference. Certainly one that's spanning 2.5 days. There's nothing like it, hasn't been in the past. Just what we need. And I think I saw the photographs of the speakers who really will deliver on this topic, not only today, but for the next 2 days. So my perspective is the young adult achieving an A status, and that A up at the top is supposed to be adolescent, but the YA is obvious, I think, at this point. And it's become not just AYA, but AYA-O. And as I've noticed across the landscape, there's AYA other disciplines, AYA nephrology, cystic fibrosis, diabetes, so forth. So it's become quite interesting that cancer, again, has led that AYA effort. And I will stick to the epidemiology and let Julie cover survivorship and so forth, although I'd like to share one idea of survival if I have the time. As far as personal disclosures are concerned, Sigma Tau. It used to be A. Affleck up there, quack, but I simply follow the Affleck Foundation now. As far as the epidemiology, as far as incidents, new cases are concerned, and we're going to speak to the United States in particular, if not exclusively, at least I will. I'm not sure about Julie. And so that rectangle over the earth is in fact North America. And here are, year by year, single individual years of age from birth through 85, the incidence per 100,000 in the largest SEER program, now representing 29% of the United States, having had that occur in the year 2000. So we have 12 years of data from 2000 and 2011 that allows us to look carefully at the incidence as a function of age. Notice that the AYA years are at the nadir. That although here we sit thinking about the problem that's much greater than what you just noted in terms of a nadir, it is in fact the lowest incidence. But I think that underscores or overstates the problem. Now let's try to look at that more carefully. If you look at the first peak and look at the descent after the peak at age 2 to 3, so from the years of age 3 down to 10, if you plot that on a semi-log curve, and I'll have done this for you in a future slide, it's linear on a semi-log curve, meaning log of incidence versus year of age. And so there's an exponential regression here, which is the best fit on the left to those data from ages 3 to 9. Then if you look on the right, and the same thing with the semi-log curve, if you look at 40 and above, it's perfectly linear on a semi-log chart. So here's the exponential regression in those dashed lines of those two youngest and older age groups. The AYA interval doesn't have that relationship. It's a different dependence, a different function. This children's oncology group, 25 to 30 years ago, even more, the Rome Conference was in 1976, so it's almost 40 years ago, decided that age 10 was a critical point in terms of deciding whether a child versus a teenager had a lower or higher risk of ALL. So we defined back then in the children's cancer group and in the pediatric oncology group 10 and up as high risk. That has refined somewhat in the last few years to the very high-risk patients starting at the age of 13. And if you start looking at that incidence pattern in the background, you begin to see something that resulted in Rome almost 40 years ago, has been refined more recently in the children's oncology group to indicate what that relationship is between the incidence and the age. Let's look at, by the way, the area under the curve between the solid line, which is every year of age, and the exponential regressions, the dashed lines. That area represents over 800 patients per year with ALL. And if you think about children who have a little over 2,000 per year, there's almost half as many just in the AYA group. And of course, children have had all the attention over the last 4 or 5, even now 6 decades. Let me repeat that. The area under the curve above the dashed lines and below that solid line of incidence represents over 800 and is increasing. And I'll come to that in a moment too. So there's a hump or a peak there. In fact, in boys, there's a distinct peak. In males, it's really obvious. If we look for that hump or peak in races and ethnicities, we find it in almost every instance. You see the lowest curve, Asian Pacific Islanders, the middle one, non-Hispanic whites, and the top, Hispanics. If we were, and this is actually on a semi-log curve to show those differences more readily, separating them by using the semi-log coordinates. Native North Americans and Alaska natives, the Indians and our natives to the north, don't really show that. That's that red jagged line. There's so few of them to not know whether there really is that kind of dependency or it doesn't occur, perhaps, in the native North Americans. The black curve behind it, jagged line, is our black African Americans, and there may be hump there too. I think you can almost see that, so I'd rather think it's there as well. And other than the group with the fewest number of persons to be able to assess this relationship, all races and ethnicities have this intermediate peak-like incidence. There's the African American black line. Now, I did take all of the patients in the SEER database from 1975 to 2011, of which there are 55,616 such persons with ALL, and noticed again, and you can go back each decade and see that peak. The peak has always been there. It's growing, it's increasing, but it was there in the earliest data. And if you consider the linearity, now this is a log curve, semi-log curve, log of incidence versus age, and you can see how linear that relationship is above the age of 40. And then there's the childhood peak, and I would say just on epidemiology alone, there is evidence for AYA, ALL, probably to the tune of 900 or more persons per year, excluding those with the childhood or the adult type of ALL in this 15 or 10 to 40-year interval. I mentioned this already, but let's look at the data, some of which was presented several years ago at the Chemotherapy Foundation. On the far left in red is the incidence in 15 to 39-year-olds from 1975 to 2011 of ALL. Straight line, essentially, linear on a linear coordinate display. The inset to the right, also with the red line, smaller graph, is of the estimated annual number of persons between 15 and 39 with ALL, but it's the most recent years from 2000 to 2014. And you see that in those 13, 14 years, somewhere from 800 per year, 15 to 39-year-olds, to over 1,000 have now been diagnosed to have ALL as of the year 2014, so these data project. And in the upper right corner, you see that this age group has had the highest incidence. That's the average annual percent increase over the years 1992 to 2011. In red, 15 to 39-year-olds, in green, children, and in gray, the older adult and oldest adults. I'll skip those. What about deaths as a function of age in the United States? Now, whereas everything I've shown you so far was based on the SEER sample of 29% of the United States from the year 2000, these are all deaths in the United States. And although the title is labeled Incidence and Death Rate, I'll show you incidence in a moment, this is the death rate in red as a function of age. And if the incidence is indeed higher in the 15 to 39-year-olds, there ought to be an increase in the deaths, unless therapy has been so good to flatten this hump. Well, as you can see, there is a peak, at about 20, 25 years of age, and the number of deaths per 100,000 adult people in the United States. And of course, on the far right, you see, because the disease is invariably fatal at my age, it's 99% fatal. There's obviously a much higher death rate. Now, if we were to superimpose the incidence curve in black, which you've already seen, and then attempt to look at the ratio between deaths and new cases, each of those age groups during the last decade, 2000 to 2011, and we just look at the ratio, there is something else that indicates that AYALL is distinct from the other age groups. And if you take the exponential regression of the years that do not include the AYA years, again, that area under the curve between the dotted line and the dashed line is, I believe, some manifestation of AYALL. And it's distinct from the other ages, younger and older. Years ago, when almost everybody died of ALL, this would be 1972 to 1981, although we had made strides already in the youngest patients, this was the death rate, number of deaths in the United States. Between 5 and 10, almost 2,800 deaths from ALL in that interval. More recently, in 2002 to 2011, we've cured and prevented death in children, but we now have, in 20 to 25-year-olds, a higher death rate than in younger or older children. So the 20 to 25-year-olds are dying in this country more than any other age group in terms of at least up to the age of 40 in this chart. So I took in this comparison the most recent decade, 2000 to 2010 or so, to the decade 3 decades ago to make this comparison and to let us know that the AYALL issue has become a challenge in the last 3 or 4 decades. And it's due in part to the increasing incidence, which I showed you, but it's also due to the lack of progress in improving the survival and cure rate of this age group. So just before Julie, I do want to mention progress. I tend to focus on the problems, but we've made some solutions and achieved at least this much. In green are children under the age of 15, in red those between 15 and 39, the AYAs, and then all those older in gray at the bottom. This is the annual 5-year relative survival rate, straight from the SEER data, and it starts in 1975 to the most recent 5-year interval that one can follow for 5 years, 2006. And you can see that all 3 of these have gone up, at least to some degree. Maybe not my age group, although in the last 20 years or so I see some benefit. But if we did, again, a regression, now we have a polynomial regression, we can see what's happening to the 15 to 39-year-olds is starting to level off. We had done quite well until the last 10 years or so. And of course, in children in green, you also see a very nice polynomial regression. Oh, by the way, before we leave this point, even though we've made progress in the 15 to 39-year-olds, that polynomial concave, or now convex, I guess, curve going up, in the most recent available year, 2005, 2006, follow for 5 years, only half of the patients are surviving 5 years or more. 50% death rate within 5 years among 15 to 39-year-olds. So that gap in the red arrow zone is what we're here for. Let's look at the age 15 and under, less than 15-year-olds for a minute. I think this is, because we've struggled over the decades to try to improve this, reaching an asymptote, a plateau that probably will not allow us, and we'll let Peter defend and explain this, whether we can ever get ALL above 90% long-term survival rate across all young people with ALL. So I'll come back for a minute. So is there an asymptote there? Well, I sure hope we're not reaching it with 15 to 39-year-olds. And I doubt it, just a little concerning the way that polynomial curve is starting to flatten out already. I'll skip this. So last, evidence for AYALL, I think you've seen this. The incidence relationship. The death improvement, we didn't do this. So this is the average annual percentage improvement in the death rate although heights of those bars are 1% or so per year reduction in the death rate, except for 20 to 30-year-olds. They're a quarter of the average of the rest of the age groups, 0.22, 0.29 for the 15 to 25-year-olds. And then lastly, reading into Charles and others here to talk about biology, this was published in 2008 out of the UK. The known karyotypes, immunophenotypes of ALL in color. You see in pink the pH positive Philadelphia chromosome types of ALL, which are only a percent or two in the first years of life, but go up to 40, 50, 60% even in the later years of life. If you take this and turn it upside down, we knew less about AYAs in terms of their karyotype than any other age group. The peak of unknown or, quote, normal, can't find an abnormality based on what we learned from children and adults, is in the AYA age group. So here's another, I think, expression of AYA-ALL. And now we have, at least to some extent, defined, and you hear this at this meeting, that there are PH1 type ALLs with either the cytokine receptor-like factor or not, that explain some, but again, notice, not all. In fact, not even half of the unknown AYA-Ls, phenotypes, immunophenotypes, karyotypes. And lastly, before Julie, lymphoblastic non-Hodgkin's lymphoma, which we treat as ALL, at least we have been for years, 20, 30 years, 40 years even, in AL in children. I've superimposed their incidence, their 5-year survival rate in dark green over the 5-year survival rate in the background, the lighter green curve for ALL. Very similar. Lymphoblastic ALL, lymphoblastic NHL, and ALL have the same relationship as a function agent in the survival rate. So I think this is evidence that we should do this at all ages. But lastly, the proportion of all ALL and lymphoblastic non-Hodgkin's lymphoma, so add those two together, the proportion that is lymphoblastic NHL, non-Hodgkin's lymphoma, is shown here, reaching a peak of about 16%, but being lower at every other age group except AYAs. So we got a bigger problem with lymphoblastic lymphoma too, and we should remember that at this conference as well. Okay, we need Julie to fill in now what I've missed. Is Julie available to roll? I know Julie, oh, there she comes, all right.
Thank you so much. So it feels like July 21st, I guess, out there, even though it's October. There will be a fall at some point in Southern California, they tell me. I was really honored. Thank you so much for inviting me to join Dr. Bleyer and talking about the epidemiology of ALL and AYAs. And I wanted to take an opportunity to talk a little bit more about the impact of the sociodemographic and health system factors a little bit more. I'm at City of Hope, not too far away, in the Population Sciences and Pediatrics departments. So I know I don't have to remind this audience, but the NCI defines AYA oncology as a discipline that's caring for patients diagnosed with cancer between the ages of 15 and 39. And while they share diagnoses with older and younger patients, we just haven't seen the same improvement in survival over time. And this phenomenon has been termed the AYA gap. And in light of this, the NCI has deemed AYAs to be a vulnerable population. So thinking about sociodemographic factors then for a minute, I'm going to show you a bunch of different studies, the majority of which were done in AYAs, although some will include adults as well, and some will include the entire age spectrum. First, thinking about geography. So geography has been shown to be associated with clinical trial enrollment when looking at it in a general way, looking at 3 large geographic areas, as well as higher stage at diagnosis. There was a modest association in looking at census regions. But in looking at urbanicity in particular, there was no effect on advanced disease at diagnosis. And using zip code centroid, no effect on the use of a pediatric subspecialty center. And again, they all include ALL, but not all of them are focused specifically on ALL for numerous reasons, of course. Socioeconomic status has been associated with clinical trial enrollment. And then survival in leukemia, most particularly in non-Hispanic whites, especially the older AYAs, the 30 to 39-year-olds, as well as advanced disease at diagnosis in Hodgkin's lymphoma, particularly in the lowest socioeconomic status. And then this is a systematic review that looked at socioeconomic status and the impact on survival and its association with survival. When they looked at studies performed in low and middle income countries, 100% of the studies were associated with survival. In high income countries, a majority, 73%, were associated with survival. And then looking at Hodgkin's and non-Hodgkin's lymphomas, in Ontario in particular, there was no effect on survival. Income and education, which are a component of socioeconomic status but have been studied separately as well, area poverty was associated with clinical trial enrollment. And at the zip code level, income and education have been had a modest association as well with a higher stage of diagnosis. Education in and of itself was associated with a coverage discontinuity when we're looking at payer. And income was associated with the receipt of definitive therapy. And again, another study found no effect on advanced disease. In particular, looking at ALL, comparing Canadian patients and US patients over a couple of decades. In the 1 to 14-year-old patients, does this work as a in the 1 to 14-year-old patients, there was consistent improvement in survival over time in both the US patients and the Canadian patients. It's not showing up so well. In the 15 to 19-year-olds, trust me, I know it looks like it's quite faded here, sorry. There was consistent improvement in survival over time, both in the US and Canadian patients. However, when they looked at the 20 to 29-year-old patients, there was no improvement in survival over time in the US patients, but there was in Canada, which leads us to believe that there were health system factors at play in this story. So thinking about these health system factors in particular, first, payer. So payer has been associated with lag time to diagnosis in a single institution study, as well as survival in leukemia, particularly in patients with no insurance compared to those with insurance, with higher stage of diagnosis in non-private versus public or uninsured patients, non-private versus private patients. And then in Hodgkin's lymphoma, advanced disease at diagnosis in patients who had public or no insurance, metastatic disease at diagnosis in the uninsured patients compared to any insurance, and receipt of definitive therapy with no insurance, but no association with time to treatment. Now thinking about treatment site, has been associated with clinical trial enrollment when looking at NCI-designated comprehensive cancer centers or CCOPs, as well as age, looking at use of a pediatric subspecialty center or COG site in 15 to 19-year-olds. Was not shown to have an effect on advanced disease at diagnosis when looking at comprehensive cancer centers or teaching programs. Was associated with survival in ALL in particular in 15 to 19-year-olds, and here we're talking about the COG sites in particular, and with race in COG sites, looking at 15 to 19-year-olds as well. So now looking at a little bit of the details of some of these studies. So this is the Utah Cancer Registry, in which when patients were aging from 0 to 24, you saw decreasing use of the Children's Hospital with increasing use of the University Hospital, as well as any of the American College of Surgeons cancer centers, as well as these gray sites were represented anything else, so basically all others, as they got older. In particular, the ALL patients had a higher rate of using the Children's Cancer Center as compared to the other diseases, but did have a number of patients still using the University, ACS, and other sites. In their multivariate, is it really not showing up, is it? In their multivariate regression analysis, they looked at predictors of using the children's cancer sites, the COG sites, particularly in 15 to 19-year-olds, and they found that disease was a significant predictor, with leukemia having a 14-fold higher risk of odds of using the cancer center, and as patients aged from 15 to 19, a decreasing rate of using the children's site. So then turning to the Georgia Cancer Registry, looking at risk of mortality by disease according to COG versus non-COG sites, looking at all leukemias and ALL in particular, the hazard ratio of mortality is less than 1. It appears to have a protective effect, but neither of these are wide confidence intervals that cross 1, and so neither of them are significant. But Dr. Bleyer, in a follow-up, looked at this same data and posited it all looking at adult versus pediatric types of cancers. And in general, there was, he's posing a protective effect of being seen at a COG site in ALL. So in light of that, we in our group took the next step in looking at a study looking at these factors. And so the goal was to study outcomes for AYAs 15 to 39 years of age with hematologic malignancies in comparison to children 1 to 14, and to understand the reasons for the AYA gap. The portion I'm going to show you about today aimed to study specific diagnoses within hematologic malignancies, first looking at overall survival by age at diagnosis, and then by site of care, looking at NCI-designated comprehensive cancer centers versus all other sites, and determining the impact of receiving care at one of these sites on these survival disparities at age at diagnosis, and then understanding the role of clinical and sociodemographic characteristics in accessing the care at these NCI-designated sites, as well as other sites of care. So we used the LA County Cancer Registry, looking at patients 1 to 39 years of age at diagnosis, with a primary diagnosis of a hematologic malignancy, diagnosed between 1998 and 2008, and both living in and receiving their treatment in LA County. A comprehensive cancer center was considered at the age of 21 years or less, having been seen at a children's oncology group site, or at any age, having been seen at an NCI-designated comprehensive cancer center, and in LA County that includes USC, UCLA, and City of Hope. Community cancer care was considered all other sites. So demographic variables included race, insurance status, socioeconomic status, and then age at diagnosis, year of diagnosis, and gender. Clinical variables were assigned according to ICD-03-based histology codes. And for our geographic variable, the cancer registry provides the patient's address at diagnosis, as well as an XY longitude-latitude coordinate, as well as a hospital ID number and name, from which we were able to derive the address. And then we geocoded that address into longitude and latitude coordinates using Geographic Information System software, or GIS, called ArcMap, using US Streets Geocode Service. And this is the coordinate system we used, which is the XY coordinate system, and then the projection is what takes into account the curvature of the Earth. And so once everything was in the same system, we were able to measure the straight line distance between where the patient lived and then where they actually received care, the nearest place they could have received care, and then the nearest age-appropriate NCI-designated comprehensive cancer center. We did this both in ArcMap and SAS, and then performed our regression analysis in SAS. So I'm going to talk to you today just about the ALL patients in particular. And our ALL cohort had 1,380 patients, and as you would predict, the majority were 1 to 9 years of age, with an equal distribution between the 10 to 14 group, the 15 to 21 group, and the 22 to 39 group. 40% were female, and then over half were in the low socioeconomic status group, with half privately insured, over 40% publicly insured, and almost 5% uninsured. The mean distance to the nearest age-appropriate site was 8.5 miles, with a median of 7 miles. So first, looking at mortality analysis, we saw superior survival in the 1 to 9-year-old group as compared to the 10 to 14-year-olds, followed by 15 to 21, and 22 to 39. And then I performed a multivariable Cox regression analysis, so here adjusting for gender, race, ethnicity, socioeconomic status, and found that first looking in the community facilities, the 15 to 21-year-olds had a 2.9-fold higher risk of mortality as compared to the 10 to 14-year-olds, and the 22 to 39-year-olds had a 4.7-fold higher risk of mortality. Then turning to the age-appropriate NCI sites, we found that the 15 to 21-year-olds, this risk was no longer statistically significant, and the hazard ratio was down to 1.3. In the 22 to 39-year-olds, it was still statistically significant, but our hazard ratio came down from 4.7 to 2.5. Now looking at the likelihood of actually receiving treatment at a COG or NCI facility. So the proportion of patients actually treated at an NCI site, first showing you according to socioeconomic status and insurance status, the overwhelming majority of the 1 to 14-year-olds were seen at an NCI or COG site, with a smaller proportion of the 15 to 21, and the smallest proportion in the 22 to 39. The only statistically significant differences within the socioeconomic status groups or the insurance groups were within the oldest age group here. And now looking according to distance from the nearest age-appropriate site, as well as race and ethnicity. Again, the overwhelming majority of the younger patients were seen at a specialized site, followed by a smaller proportion of the younger AYAs, and the smallest proportion in the 22 to 39-year-olds. And here, the only statistically significant difference was within the oldest group along race and ethnicity. So now showing you the multivariate logistic regression analysis predicting likelihood of care at one of these specialized sites. First, looking at an analysis adjusting for all of the sociodemographic factors, just first in 10 to 21-year-olds. The 15 to 21-year-olds had a 50% lower likelihood of using one of the specialized sites as compared to the 10 to 14-year-olds, but none of the sociodemographic factors were significant. Now looking at 22 to 39-year-olds, you'll find the opposite, where low socioeconomic status patients had a 70% lower likelihood of using the specialized centers, and public and uninsured patients had a 90% lower likelihood of using the centers compared to private patients. So in summary, in ALL and in LA County, we found poor survival in AYAs versus children, with this increased risk of mortality in AYAs being greatly decreased by receiving care at an NCI or COG site, and that this risk completely was mitigated in the younger AYAs with ALL. In the young AYAs, they were less likely to use these specialized sites as compared to children, but this was not explained by sociodemographic factors nor distance to care. And in the older AYAs, those with low SES or public or no insurance were less likely to use the specialized centers. But those who lived more than 9 miles from the nearest age-appropriate site were just equally as likely to use those specialized centers. So next steps from this, because this is a hypothesis-generating study, so the next step would clearly be to explore barriers to care in these AYAs, and then there's many facets of biology, which we'll spend the next couple of days talking about here. And then to differentiate the details of the structure and the process of healthcare delivery. And so when we think about what the Institute of Medicine has generated, another report for this a second time in the last decade and a half, with a call to action, one of their points being we need to reduce disparities in access to cancer care for vulnerable and underserved populations. And based on these findings, I would posit that AYAs with ALL, and in particular some specific subpopulations, would fall into that category. And really looking at the granularity of what determines the difference in NCI-designated comprehensive cancer centers' care as compared to other sites, and drill down on what these quality factors are. The only reason we chose the use of these sites versus others is because this is the only place where we have externally validated measures that we can actually compare. So thank you for your time. I am eternally grateful for my mentor, Dr. Smita Bhatia, who's really been amazing at walking me through every step of the process in academia, and Dr. Sun, who's here with us today, who makes sure I don't mess up on any of my analyses. And Marianne Kang, who was working with us at the time. Wendy Stock, who I know won't be here with us till I think tomorrow night, has been an invaluable resource as our voice of adult ALL. And I've been grateful for the funding both of an institutional K-12 as well as the St. Baldrick's Foundation. Thank you.